I'm going to do a little more in-depth review of this PowerPoint for people who really want the electrolyte review, pointing out a few key concepts here. My first recording on PowerPoint went bad, so I am going to do it on my old trusty iPad the way I know how to do it. So we're going to look at the electrolytes real quick. I'm going to point out the BMP on here, basic metabolic profile, or basic metabolic panel. Will give you all your electrolytes that are usually needed, plus kidney function, BUN, and creatinine. The complete metabolic profile is everything that's on the BMP plus liver labs, and I did designate the difference between which ones are reading kidney stuff and which ones are reading liver enzymes, which we'll talk about more next unit when we talk about liver. You do have to order separately the magnesium and the phosphorus, and the reason you have to order them separately is we don't usually follow them as closely, mostly because magnesium and calcium are very, very similar, and phosphorus and calcium have an inverse relationship. So if you have your calcium level, you kind of know what signs and symptoms you're looking for magnesium as well, and if you have your calcium level, you know exactly what your phosphorus is doing. So we don't usually look at those independently unless we have a specific issue that we're concerned about. So anyway, the BMP is usually what we're looking at. Again, I talked to you about this in class, but I will reiterate again that these normals are not the end-all be-all. I do believe they match what is in your book. Every book has a little bit different. Every lab has a little bit different. So these are general numbers, 135 to 145. I like easy 5s, 10s kind of numbers. They're easier to remember. And remember that I, on my exams, or NCLEX as well, will either have a number that is super, super low or super, super high. We're not going to give you 146 of a sodium. But remember, if you know your normals, you know what side of normals you're on. If you know you're a low normal, if you know you're low, you're going to see symptoms that range on the hypo side. If you have numbers towards the high side, you're going to have symptoms that range on the hyper side. And then, of course, as the higher you get, the more dangerous your symptoms are. Lower you get, the more dangerous your symptoms are. So again, good things to memorize and know. But again, if we want to point out low potassium or have you put up your eyebrows and recognize low potassium, we'll probably give you 2.7 or something really low, not right at the borderline. So I do want you to remember these values just because I think they're a little bit easy to remember and they match your book. But don't stress about NCLEX or my exams. Again, a potassium that I want you to recognize as high, I'll probably put 6.7, something way out of the normal range so that you can recognize it. So we'll NCLEX. Let's point out sodium. I need to limit your lists. Your lists are too long. Sodium, major functions, fluid balance, and muscle contraction. The two things that we're looking for. So when you think of sodium, I want you to think of fluid and muscles. Fluid and muscles with sodium. When we look at sodium, you're going to look at what is it doing to your fluid level and what are you going to do for your muscle level. Well, we could have a whole list, but really the most sensitive indicator of your fluid balance is what's going on in your brain. Okay. Yes, peripheral edema. Yes, you have edema. Yes, you have lung sounds. Yes, you have all those things. But if your tissues, in general, your vital tissues are being overhydrated or underhydrated, we will see that in your brain. If you've ever had a hangover, you know how fluid balance affects your brain. So when we are talking with sodium, I want you to pay attention to your brain, and I want you to pay attention to your muscles. Fluid balance and muscles. So with any hypo or hypernatremia, we are going to be monitoring our brain and we're going to be monitoring our muscles. So we're going to pay attention to the brain. The brain tissue is our most sensitive vital tissue to fluid deprivation and overload. So when we are cerebral overload, and let me just draw a quick little picture on here that, let me get my little pen out here, and draw our vessel here. So what we are doing when we are hyponatremic is we have, this is our blood vessel. We have very little, and I'm just going to write N's for sodium. So in the vessel, it's, you know what, I'm a bad drawer. Hang on one second. Let me pause this for a second and clear this off. I'm going to try this again here. We're going to draw our little vessel here. And in this blood vessel is a very small number of sodiums, 2 sodiums in there. On the outside, in our, we're going to call this our brain tissue, is normal levels of sodium. Now, if you were fluid running through this vessel here, what are you attracted to? You're attracted to high levels of sodium. This is the house party that you want to attend. You go out here to the tissues. So all of the fluid is moving out of the blood vessels into this delicate brain tissue, causing swelling of the brain tissue and giving you a headache, basically. When your brain gets kind of overloaded and swollen, you get a headache. You get a little bit irritable. And that's what's going to happen until what we're going to do to treat the problem. So if we don't treat the problem, this will continue to happen. This will always be saltier out here until they reach a balance. And that balance will be when this sodium gets diluted down out in the brain tissue. That could happen way, way late. And the story that I like to tell with this one is the hiker. Okay, so what I'm going to do is clear this all out again. And let's talk about our hiker here. Here's our hiker. He's out hiking. And let's just say this is, we've got normal sodiums in our blood, and he's processing, and he's enjoying the hike and looking at the birds. And what is happening is he's sweating. And so normally we have equal levels of sodium all around. Well, he starts to sweat, and now he's lost sodium out of his sweat. He's also lost some fluid. So what does he do? He drinks his water. Let's tell him he's drinking plain, regular tap water. So he's increasing the level of fluid and staying hydrated, but he's not giving himself any sodium. Where's all this fluid attracted to? Dang, dang, tissue. The hyponatremic patient, because he sweated out all of his sodium and his fluid, he replaced his fluid, but he didn't replace his sodium, and he now is starting to brain swell. If you've ever heard of the hikers that have water intoxication, that's what this is. Hyponatremia could be water intoxication. He's drinking so much free water that all this free water is now attracted out to the salty areas of his brain tissue, and his brain is swelling. He's starting to get confused. He's starting to get dizzy and woozy. It's not because he's drinking more water. And the water then goes out into the tissues of the brain cell. He starts getting more and more confused, and he's basically swelling his brain. Now let's talk about the hiker who now drinks Gatorade instead. So here he is with his 3 sodiums, and he's got the 3, so he's all in balance. He's out enjoying his hike, and it gets to be hot, and he sweats. So he's out here, and he sweats, and he starts losing his sodiums. So instead of, let's see, let me make this right. Let's do his tissues out here so I can drop his sodiums out of his blood cells. So here we go. He's hiking, and he's sweating, and so his sodiums start decreasing. But then he ends up replacing his fluids with electrolytes, which have fluids and sodium in it, and he stays balanced, does not get water intoxicated. So that's kind of a little bit of what's going on behind the scenes there. But whenever our tissues get our vital tissues like our heart and our brain get overloaded, they get kind of silly. They don't work. Swollen brain cells, if they start swelling with fluid, let's go back to the water intoxicated guy who's just filling himself with fluid but not sodium. Now all this is going out into the brain cells and puffing up these brain cells. These brain cells are so puffy and big, and when they're puffy and big, they can't transmit signals amongst themselves very well, and they start getting confused, and you start having the problems that you're seeing there. So that is our water intoxicated patient, why cerebral overhydration is a problem. Diminished muscle reconductions, well, that sodium's not existing around to conduct your muscles, and you end up feeling weak and woozy. And you don't have an unsteady gait, you get wobbly legs, you're not feeling that great. So we are watching the brain, and as things get worse, you will become less responsive to verbal stimuli. You'll lose your ability to tell where you are, and you could even have seizures, and not because there's something inherently wrong with your brain, it's just too swollen to pass messages along very well. Weak respiratory muscles, we worry about shortness of breath, weak respirations, but again, you're going to see mental status changes before we start seeing that severe muscle. We're going to see the swelling in your brain first. And the brain's very delicate. So we're going to go ahead and treat this now. If with the hiker that treated themselves with Gatorade, we never got to this issue. But let's say we get the water intoxicated patient in, and this patient has these big swollen brain cells, and he's fully water intoxicated with, he's got tons of fluid and only 1 sodium. So what do you think we want to give to this guy? We want to give him sodium. We're going to put in an IV and put in some thick sodium. We're going to basically give him salt. So we're going to give him sodium, a lot of sodium. Now what's going to happen to the fluid here? Fluid's like, dude, the house party moved in here. We want to come, excuse me, sneezed. The fluid's going to come out of these cells into the blood vessel where there's more sodium, and we're going to start shrinking those cells, and that will decrease your cerebral problem. So what we're going to do is we're going to give saline IV fluids, get that salt level up in the blood vessel, and get the fluid shifting to the right place. Why would we do a free water restriction? A free water restriction is because we don't want more fluids getting into the system. They're already probably water intoxicated. They've already got lots of thin fluid running around. We don't want to put, we want to put salt into the system, not more water without electrolytes. You can see there are 2 different kinds of causes here. These causes are actually losing, let me go back, sorry, I'm drawing on the wrong place here. These causes are actively losing electrolytes, which means we've actually dumped our sodium out of our body. These causes here are water overload or fluid overload, where we have too much water in the system. We may have normal levels of sodium, but it's diluted it out. This is kind of our Kool-Aid example from before, where we have a lot more water in the system than sodium in the system, so it appears hyponatremic. Either way, we want to put sodium into the system until we can deal with the causes of the problems. We're going to either rehydrate or dehydrate if you're water intoxicated. We're going to move fluid in and out of the vessels, but we want to make sure our sodium levels stay adequate. So really what we're going to do with a patient, when you're going out and sweating, that's when you are, if you have, or you're taking laxatives, or you're taking diuretics, or you're sweating, or you're vomiting, or you have diarrhea, you're going to want to replace your fluids with something that has electrolytes in it, because what's happening is you're losing your electrolytes. You want to replace those electrolytes. If you have something like heart failure, cirrhosis, SIADH, which we'll talk about later, where we're getting fluid overloaded, we want to remove the fluid but not the electrolytes. So that's a little bit, sodium gets a little confusing if you're just trying to memorize lists unless you understand what's going on behind it. Let's look at our hypernatremic patient. If we're going to draw a blood vessel on this patient, let's draw our little blood vessel over here. This patient has tons of sodium. So our cells out here have sodium in them, but we have so much more sodium in our blood vessels than we do in our tissues. Where's fluid going to go? It's going to go into the blood vessels. This is the house party. So what you're going to see is you're going to see your brain, your delicate brain tissue, which is the first tissue we're looking at. By the time you see any kind of peripheral edema out of these, you're way far down the balance. Excuse me, sorry. So my vessel has disappeared here. So we have too much salt. So lots of salt, lots of salt, lots of salt, lots of salt, lots of salt. And we have these are our little brain cells. What has happened to our brain cells here in this salty system is that water's attracted to the salt party. So here we are, we're going to leave these cells and we are going into the giant salt house party that's going on in the vessel here. So now we are filling up this vessel with salt, and these vessels are becoming shriveled, dehydrated. This is exactly what happens when you get a little bit dehydrated after drinking. Your brain cells get shriveled up and dehydrated a little bit in order to pool blood in here. So we've got tons of fluid in the vessel, and there's still tons of salt in there, so we're still pulling fluid into the vessel. So the vessel is getting increased blood pressure because it's got more fluid in it. We're getting peripheral edema because when you have a vessel that is full of fluid till the pressure's high, it's going to leak. And it's going to leak in 3 places. It's going to leak in the places where vessels are very permeable. Vessels are permeable in your hands and in your feet, in those capillaries there in your extremities, and vessels are very permeable in your lungs. And so when you have a high blood pressure and a lot of fluid overload, fluid will leak out of this house party no matter how bad it wants to be there. It's getting pushed out. The house is full to the brim. People are coming out the windows. And it's going to come out in places where the vessels are weak and easily permeable, and that will be in your capillaries and in your lungs. So what's going to happen is that inappropriate fluid's getting pushed out of this big old vessel party going on by this high blood pressure, and it's going to get pushed out into your hands, into your feet, and into your lungs, which gives us the symptoms of fluid overload. Yes, they have a ton of fluid still circulating around in the vessels, and while the sodium level is high, it will continuously pull fluid from your vital tissues, being your brain, your heart, your kidneys. It will pull fluid from those tissues and then leak it out at inappropriate places like your hands, your feet, and your lungs. We don't need the fluid there. It's leaking out of there because that's where the capillaries are very weak and permeable and will get pushed out from high pressure. So what we're seeing is cerebral dehydration because it's getting sucked out of those vital cells, put into the vessels, and then it's leaking out later on because the pressure is so high in the vessels. So we're going to get cerebral dehydration, and we're going to get fluid overload showing up as high blood pressure in our blood vessels and as pulmonary edema and as peripheral edema because that's where it's leaking out inappropriately. So vital tissues don't have fluid and inappropriate tissues have fluid. That's what happens until we worsen it. So what do we do to fix it? And what we see when we worsen it is we're going to see pulmonary edema because that's where it's leaking out because we've got high fluid volumes. It's got nowhere else to go. It's going to leak out the permeable vessels into the lungs, giving us crackles. That's the sound of air moving through fluid into the lungs. Crackles. Frothy sputum is actually us coughing out fluid from our lungs. We're going to see edema in our feet, our hands, and our toes because that's where our capillaries are that are very loose, and we're going to see fluid getting pushed out of this big fluid-filled vessels. To get rid of this, we need to get rid of the extra fluid first, so they will use diuretics. Now, unfortunately, our vital vessels, our vital cells are dried up. Our brain is dried up. Our kidneys are getting dried up. Diuretics are going to cause a little bit of a problem. They will help us get rid of the extra sodium. We'll dump the sodium. We'll dump the fluid. But now we need to put fluid back in. So let's say that now we gave this patient a diuretic. So we put in an IV and we gave him Lasix. Okay, there you go. Have 40 of Lasix. What is going to happen to our cells is it's going to we're still dehydrated here, but now we've lost some fluid out of this house party. We've lost some of the sodiums here. So let me, where's my scribble eraser here? We're going to erase some of the sodiums. So basically, we gave the dose of diuretics, and here's what our vessel looks like after the diuretics. We've got a lot less fluid because we peed it out, and we've still got some sodiums in here. We peed out some of them, but not all of them. Unless we fill this vessel with hypotonic IV fluids, we still have more sodium in this vessel than outside. We're still pulling. We're still dehydrating this thing. We give them more diuretics. We put more Lasix in the system. And now we've cleaned this out and we flushed it out. And now we're getting to the point where we're out of fluid. So let me erase. We give the other dose of Lasix. And now we're very dehydrated here. These guys are still dehydrated. And now we're right down. We've finally gotten rid of fluid and electrolytes. Okay, we're down to this normal level of sodium. But how do we get fluid back to these dehydrated cells? Well, that's why we're going to give hypotonic IV fluids. We're going to put in thin liquid like water. Not much saline, because we just worked really hard to get not saline. We don't want to put more salt in the system. We just worked really hard with the diuretics to get the salt out of you, salt and extra fluid. We want to put fluid back in, but we want to put fluid back in that we plump the cells back up. So what we're going to do is we're going to fill this up with thin fluid that's going to dilute out the sodium. And now where's the sodium party? The sodium party is now out here in the tissues, and it will push it out. So the first thing we're going to do is diuretics, secrete out the sodium and the extra fluid. They're going to dehydrate the vessels. Yes, we are. But we need to now put in fluid that's going to push fluid back into these dried out cells of our kidneys and our brain. We're going to give hypotonic fluids that will push fluids back out into the cell. We will let this patient drink water without electrolytes in it. We just had too many electrolytes. We had too much sodium. So we're going to go ahead and let them have hypotonic IV fluids. We're going to give them diuretics. We're going to get everything cleaned out. And then once they all get plumped back up again and rehydrated, we will change the IV fluid over to regular normal saline, which will fill their vessels, keep their vessels filled, but no more fluid shifting. So I hope that makes a little bit more sense with what we're doing to treat high sodiums. We really need to get the sodium out of the system and then replace it with some watery fluid that will then rehydrate the cells. So hypo and hypernatremia. Hopefully that makes a little bit more sense for you guys. Here are your sodium foods. For potassium, I want you to remember heart. Sodium was involved in fluid balance and some muscle. Potassium is involved in heart conduction and contraction, and some muscle. We're going to see the effects in the heart first. With sodium, we're going to see the effects on fluid balance first, then muscle. Here we see effects on heart first, and then muscle. So yes, even though we're assessing muscle and heart, the heart effects will be seen first. Low potassium causes a slowing of everything, slow, weak contractions, slow, weak conduction. So everything is depressed. And this will show up in your heart rate because potassium will show up first in your heart. So we're going to see fluid first is sodium. With potassium, we see heart first. We see the changes happening on the heart before we see it in the muscle. So you will see this depressed ST segment, this kind of slowing of the heart. With too much potassium, your heart is overexcitable to the point where it can't even reset, and it ends up getting wider and wider, and almost it could fibrillate because it's so overexcited. So when we're looking at this, you can see cardiac is our number one issue to look at, whereas cerebral overhydration or dehydration with sodium. Here we're looking at cardiac changes. So we are wanting to put a camera on our heart right away. We're going to see changes in our heart before we see changes in our weakening muscles. So if we have the point where our muscles are getting diminished, you're getting weak, your bowels are slowing down, you've probably already got heart changes going on. So we're going to put the camera on the heart first if we're considering a potassium problem. If we do let this go on for too long, then we will see that the heart conduction will slow even longer. It will get wider. It will get missed beats, and you can actually slow it down to cardiac arrest. If we are at the point where we have weakened our muscles to the point where we're having shallow, weak respirations and shortness of breath, by golly, your heart's already had the issues. So when we're watching potassium problems, we want to look at our heart. Our heart is our telltale sign. If we start seeing heart changes, then you have muscle changes as well. So the heart is more important here with your potassium. So put them on a monitor right away. We want to see if they are low potassium, meaning less than 3, 5, then we're going to want to keep an eye on their heart, because if it's low, if the potassium gets any lower, then we will start seeing that ST depress, and we will see changes in the EKG before we're going to see weak muscles. If we're already at the point where we're really, really weak muscles, then we know we have cardiac problems, and we definitely want a camera on our heart. So while we are looking at muscle reflexes and bowel sounds, I will tell you that by the time we see changes in respiratory rate, muscle reflexes, and bowel sounds, we are definitely having cardiac problems. So please, first thing with any potassium, put on the cardiac monitor. If they're low potassium, we're going to give them potassium. Potassium pills, just know that they are best absorbed in an acidic environment, so something empty stomach with some water or juice. Because when we give potassium, it's going to overexcite the area a little locally. You may get some GI cramps. You may get some abdominal distension and pain as everything kind of gets going in there as you absorb the potassium. You can give IV potassium for a quick jolt, but I will tell you, if you have to give a lot of potassium replacement, giving it peripherally is going to be a slow way to do it, because potassium causes vasospasm as it enters the cell. Remember, it's making everything excitable, especially in the muscles. When we put that into a blood vessel, it will cause vasospasm of that blood vessel, and it will hurt. It's also toxic to the vessel, can infiltrate very easily. So it's very irritating. There is a limit on IV potassium, no more than 10 milliequivalents an hour peripherally, and no more than 20 milliequivalents an hour centrally. It is never, ever, 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 ever an IV push. Never, ever. You can always bring it slower than that, but you cannot go faster than 10 milliequivalents an hour peripherally and 20 milliequivalents an hour centrally. So if you have to give 40 milliequivalents of potassium, it's going to take you 4 hours if you only have a peripheral line. So you'll see us probably trying to give it orally rather than IV. It's much more efficient. And it's just much less dangerous to give it orally rather than peripherally. But you can do it IV, but they will complain that it hurts, and it does have limits on it. Hyperkalemia, high potassium. Again, we worry about the heart. We worry about the heart getting so excitable that it can't calm down and it can't relax, and it can cause an arrest because of basically the heart gets frozen. It gets so overstimulated, it gets frozen up. So can the muscles, but again, we're going to see cardiac changes first before muscle changes. With high potassium, we need to get the potassium out of the system. We have to get it out of the body, and the best way to get it out of the body is either diuretics, where we pee it out, or K-exolate, where it binds in the gut and gets pooped out. Diuretics, you have to be careful. Make sure that you have the fluid to give. Yes, we want to get rid of potassium, but do we have room? I mean, a dehydrated patient that you want to get rid of potassium, diuretics are not the best choice. So K-exolate is the drug of choice. It is a potassium binder. It pulls potassium from the gut circulation and will then poop it out. We can do a few things. The only things that will get rid of potassium are K-Exolate and diuretics, and of course dialysis if we really, really need to. That's very invasive. And a last choice, K-Exolate is very easy to give. It's an oral, very easily tolerated. Again, least invasive to most invasive, we're doing K-Exolate, diuretics, and dialysis. Those are the only ways to get potassium out of the body. We can hide potassium from the heart because really we just don't want the potassium getting overexcited from all this potassium circulating around. There are two ways, dextrose with insulin and calcium gluconate. Those will do two things. The insulin, the reason we give that has nothing to do with diabetes. Insulin takes potassium with it when it enters a cell. So what we do is we'll give the patient 10 to 20 units of insulin, and the insulin, as it goes into the cell, takes the potassium with it. It's a great way to get the potassium out of the bloodstream temporarily so that it doesn't affect the heart until the K-Exolate or the diuretics can take effect. You have to give dextrose with it because most patients can't handle a shot of 20 units of insulin without going hypoglycemic. So they give the dextrose with it so that we're using the insulin basically as a carrier. But we don't want to cause hypoglycemia with that insulin. And insulin is just a nice way to hide the potassium. It is not a long-term fix. It's not the best treatment. It's just a way to hide a super high potassium from the heart. But again, K-Exolate, diuretics, and emergency dialysis are the only ways to remove it. That just hides it until we can get our removals on board. Calcium gluconate will basically immune the heart from the presence of potassium. It will protect the heart from the potassium until you can get your treatments on board. So I think that's what I want to point out with hyperkalemia. Your key and your only ones that will fix the problem will be K-Exolate, diuretics, or dialysis. Dextrose with insulin and calcium gluconate are temporary measures to protect the heart from the potassium until the diuretics or K-Exolate or dialysis can work. Foods high in potassium to give to people that are hyperkalemic and to avoid if you are hyperkalemic. I'm going to let you pause. We did this in class, but I'm going to let you pause. Just hit pause on this recording while you read it over and take a look. And I'm going to tell you that this is going to be 3 correct answers, but you got to pick one. So this patient has weak, tired, and hasn't moved his bowels, is constipated. So you're saying, okay, weak muscles, could be sodium low, could be potassium low, could be high calcium, could be high magnesium. I don't know where we're going with this, but now they're telling you heart. So we know our electrolyte involved in heart is potassium. So we're now moving towards potassium, and we're moving towards low potassium because of the slowing down and the depression of your muscles, as well as we have heart issues. So you check the MAR and you see that they're prescribed furosemide, and you're already kind of going towards low potassium because of our cues. So do you want to give the furosemide? Furosemide is going to waste more potassium, and you're already suspecting low potassium. So what do you do? I will tell you that when you are given 4 choices like this is not asking you to, what do you do next, and then next, and then next. It's saying you're going to do one thing and then leave the patient for the rest of the day. So do you hold their dose and move on with your day? Do you give them a glass of orange juice and move on with their day? Do you teach them about foods high in calcium and go on to your next patient? Or do you put the patient on telemetry and notify the physician before going on to your next patient? Well, when you say things that way, things make a lot more sense. You would definitely want to hold the next dose of furosemide. I don't want to give that. I know it's going to cause potassium wasting. But do we just want to hold the dose of furosemide and do nothing else? Not your best choice. Do you want to give them a glass of orange juice? Well, we know orange juice is high in potassium, and if I think my patient's low in potassium, it's not a bad idea. Do you want to give them foods high in calcium? I'm not worried about calcium right now. The slowing and everything has nothing to do with low calcium. Low calcium, my patient would be tense and rigid, he wouldn't be this slow. So I'm not even worried about calcium. I'm crossing that off. I'm trying to decide. I liked furosemide. I liked orange juice. I like put them on the telemetry monitor and notify the physician. So of these three choices that I have no other choices in my life. This question is these three choices. I can do one of these things and then go on to my next patient. Which one will make the biggest difference in this patient's care? I can do one of these things and then I got to go see my other patient. Putting them on the telemetry monitor and notifying the physician will get you closer to diagnosing what's really the problem. We only suspect low potassium. We can't assume low potassium. It's not telling you you have low potassium. There could be many other things causing this. We need to take a look at what's going on. What is that irregular heartbeat? We need more investigation. We need more data. If you just hold furosemide, maybe that was the wrong thing to do. Maybe he didn't have low potassium at all. Maybe giving them orange juice wasn't enough if they did have low potassium, and maybe they didn't have low potassium at all. Put them on the telemetry monitor, notify the physician. Best answer for this situation. And you can read all of that. Calcium, I want you to think muscle. So sodium, we think fluid, we think brain. Potassium, we think heart, and we think heart monitor. Calcium, we think muscles. Calcium is involved in contracting and relaxing muscles. It's involved in initiating contraction and initiating relaxation. So without calcium, we don't initiate the relaxation. The muscle stays in a contracted form. So if we have low calcium, we have enough to contract a muscle. We don't have enough to relax a muscle. So muscles stay twitchy. They stay tight. If you end up scratching your cheek and you get a little tick to remove the hand, then that stays stuck in that position. You put on a blood pressure cuff and you stimulate that nerve that goes to your hand gets contracted and stays stuck in that. Your hands, you basically get frozen. Your muscles get frozen in contraction with hypocalcemia. So they end up with tetany, rigidity, and the seizures are not from the brain. They're due to frozen muscles getting stuck. We get very concerned when our frozen muscles that are stuck are smooth muscles in our lungs, causing stridor and vasospasm. So what we're going to do is, since we see this in the muscle first, we're going to monitor our muscles first. This is where muscle reflexes are probably more important in monitoring calcemia than monitoring sodium or potassium, because yes, it's involved in the muscle, but we're going to see things happen in the brain or in the heart first. Here, calcium, we will see muscle first. You also see some areas of numbness and tingling because calcium's involved in nerve conduction. So we will see some areas of numbness and tingling in hypocalcemia, but we're really looking at the muscles. We can then do cardiac, bowel sounds, respiratory rate, but we are going to see stiff muscles prior to having respiratory or cardiac problems. Does that make sense? They are still important, but what we are going to see happen first is we're going to see something like Chose-Stecks or Trousseau's before we see a problem with respiratory rate or cardiac rhythm. So we're looking for muscle first on calcium. If we have too much calcium, and then just a little extra slide on the calcium supplements. We do have IV calcium as well as oral calcium. It's not as dangerous as potassium, still as irritating IV-wise as potassium, but not nearly as dangerous at giving it. It won't stop your heart the way potassium does. Hyperkalemia, overdose of calcium, really basically you have so much, you can't get out of contraction. Your muscles are so weak. You cannot stop you can't get the contraction going. They're overwhelmed with calcium, so they don't have that stimulus to contract. Everything is loose and floppy. Hyperkalemia is loose, floppy, tired, and then also all that calcium floating around can cause stones. It gets put into joints. but we're going to see the weak contractions. So your patient having trouble moving themselves and getting out of bed will be, and weak deep tendon reflexes will come before we start having heart and lung problems. But if you ignore it to the point where it's at heart and lung problems, we are going to have basically weak lungs, respiratory failure, bradycardia, everything kind of slowed and floppy. The treatment for hypercalcemia is to dilate it out and pee it out. We're going to flush the system with hypercalcemia. So, calcium muscle. That's where the one that with deep tendon reflexes would come first. Magnesium is our spa element. It is involved for continued relaxation of muscles. It's basically almost exactly the same as calcium. You don't need to study two cards. The only thing you need to pull out the difference is that low magnesium levels don't cause tetany and Chostek sign as quickly. They can, though. They can have tetany. They can have muscle cramps, irritability, personality changes. But low magnesium comes with a cardiac rhythm called torsades de pointes. So really, that's probably the only thing to pull out of magnesium is the torsades with low magnesium. And you probably remember from OB studying a MAG patient, you probably talked about hypermagnesemia, but this is the relaxation muscle. If you have too little, you don't relax, just like calcium, and if you have too much, everything is relaxing. Magnesium works much more in the blood vessels than calcium does. Calcium works in the blood vessels as well, but too much magnesium is going to cause you to slow down just like calcium, but it does drop your blood pressure as well. So really, you could study calcium and magnesium as almost exactly the same cards. The only thing that's different is that magnesium will have torsades de pointes if you let it go way too low, and it will have that one cardiac effect that calcium does not. Otherwise, it's pretty much exactly the same as the calcium slides. So magnesium and calcium almost exactly the same. Sodium and potassium exactly the same. But remember, your primary things to look for is in sodium, we are looking for cerebral overhydration or dehydration, and then muscle. Potassium, we are looking at heart, and then muscle. In calcium and magnesium, we are looking at muscles, so our DTRs will be our first signs and symptoms, and then things could get worse respiratory and lung-wise if we let it go. Phosphorus, I am going to say you don't need to study phosphorus. Phosphorus goes with calcium, except that it's inverse. So calcium and magnesium, one slides. Just calcium, magnesium slides, almost exactly the same. Phosphorus is inverse of calcium. If you have a high calcium, you have a low phosphorus. If you have a low calcium, you have a high phosphorus. You can look at it's basically involved in the vitamin D absorption, and that phosphorus is involved in making vitamin D work or not work. This really only comes into play, phosphorus only comes into play really in our renal failure patients, because renal failure patients have high phosphorus levels. And so sometimes they will treat phosphorus to fix calcium levels, because if you increase your phosphorus, if you decrease your phosphorus, you will increase your calcium levels. So this comes into play in renal failure a lot. But all you need to know about calcium and phosphorus is the inverse relationship. When phosphorus is high, calcium is low. If you have hypocalcemia, you automatically have hyperphosphatemia. If you have hypercalcemia, you have hypophosphatemia. They just go together. There's no ifs, ands, and buts. It's just the way it is. So you really don't need to memorize any other slides. They are the same as hypercalcemia for hypophosphatemia, and hyperphosphatemia is the same as hypocalcemia. And one last thing to talk about on these is the chloride CO2 levels. I will not test you on this. EdClex probably won't test you on this. But if you go into clinical, these levels are really only used when we are trending somebody's metabolic acidosis or alkalosis. They haven't, chloride and bicarbonate have an inverse relationship. So when someone has a high chloride level, we think they have a low bicarb level, which helps us really when you need an ABG to firmly tell metabolic acidosis or alkalosis, but rather than sticking a patient to monitor their ABGs nonstop for a metabolic problem, the doctors will trend their metabolic acidosis or alkalosis with chloride and CO2. And that's pretty much all you need to pull out of chloride and CO2 is that they are used to trend metabolic acidosis and alkalosis. That's about it. I hope you enjoyed your review of electrolytes, and I hope that made things a little more clear onto why we monitor what we do.